Good morning, everyone. Thanks for coming to the morning conference, whether you're here in person or electronically. I'm going to talk about upper extremity trauma today with focus on radiography, and I'll go over shoulder, wrist and hand, and elbow, and show some cases as well, obviously. The slides that I have are pretty basic. They're just orientation slides for the anatomy, and then we'll go into the cases. So for the shoulder, just keeping in mind the anatomy of the glenohumeral joint with the humerus here and the glenoid and the acromioclavicular joint, those are things we want to look at the alignment of here from an anterior view and here from a posterior view. The coracoid process projecting out here. On this other view, the scapular spine coming up to form the acromion. The radiography that's typically done includes an AP view, and that may have the humeral head rotated one way or another. Here's the patient with a visible light in the detector here, showing an AP view of humeral head, glenoid, and you can see the overlap that you expect between the humeral head and the glenoid by this crescent here on a normal AP view. And so since the shoulder girdle is angled relative to the body, you don't see right down the joint on an AP view. You do see right down the joint if you do what's called the Grashey View, where you rotate the patient, shooting right down the joint like this. And so in this view, the humeral head is generally externally rotated. So you see the greater tuberosity here, lesser tuberosity here. Other views that are commonly done is the axillary view, shooting through the axilla with the plate up here, or you can do it with the plate on the table and the patient kind of hunched up over it, shooting down from above, or a Y view, which is intended to look along the long axis of the scapula and demonstrate the scapular blade as a linear structure, but with the Y formed by the scapular spine and the coracoid base here, basically. So the key thing about the Y view is that the humeral head should superimpose and be pretty much centered over the Y, because that's what the glenoid is formed by. The last slide here is the classification system, which you don't have to know all the details of the Neer classification, but it's good to be aware that in orthopedics they have these different classification systems, and they do use this for glenohumeral injuries, or I should probably say proximal humeral fractures. And the idea is basically that there's different numbers of parts for these fractures. So in this upper left example, this is a so-called one-part fracture. The blue lines are the fracture lines. So even though there is more than one fracture line, something doesn't qualify as a part unless it's like greater than 1 centimeter in size and distracted by on the order of a centimeter or so as well. So non-displaced things still qualify as like a one-part fracture, 2-part, 3-part, and 4-part, and so on. So, or different descriptions like greater tuberosity fracture here, greater tuberosity and surgical neck fracture across here, and so on. So just remember that the surgeons use this Neer classification. So if we look at some radiographs now, normal to start out, and I'll try to go fairly quickly through these cases because I have quite a few, but so here's what we would probably call a Grashey view, because we're looking down the glenohumeral joint. The humeral head is in external rotation because you see the greater tuberosity here and the lesser tuberosity here, AC joint here, and here's the coracoid process projecting out. Here's a Y-type view where you see scapular spine, coracoid coming out here, scapular body, and the humeral head centered over it. Axillary view is an important one to be able to look at carefully as well. And here what you want to look for is first the orientation. And this one would be a left shoulder, because left would be here and right here. Looking down here, here's the glenoid. So this is all glenoid there, humeral head being centered up on that. And you always want to be able to know which is anterior or posterior because of knowing which way the humeral head may be subluxed. So here's the coracoid process. That's going to be projecting anteriorly. If you look carefully, and you don't often think about this, but you can see the scapular spine coming up and over to the acromion here, and you see the clavicle coming across here to form the AC joint in this projection right here. So the use of that is that sometimes patients have an AC separation or malalignment, and you can tell whether the clavicle is displaced anteriorly or posteriorly relative to the acromion on the axillary view. So if we go to some case examples here, and again, I can't really pimp you very well with this setup where I'm recording it, but here's a patient with a comminuted midclavicular fracture, and there's a temptation to be sort of finished with the case at that point because it's clearly an injury, but that's not the whole story. There is that clavicular fracture, and in that setting, you always want to check, does the AC joint show normal alignment? And in this patient, the AC joint looks like it's pretty nicely aligned. What's not really normal is the scapula here, and if you look down, there's a linear sclerotic area here, there's some increased density here, and down in here. So it's not uncommon for patients to have multiple injuries about the shoulder girdle. So here I've gone to a different view. Here's the clavicular fracture. Here's kind of the Y view. Here's scapular spine, base of coracoid, coracoid itself. And so the glenoid is in here. And what we're seeing here is this lucency through here because there's a scapular fracture that goes and cuts across the glenoid here. And then there's a displaced component of the actual glenoid down here. Now the humeral head's still actually pretty well located in this patient, but there's two injuries, and probably this injury is the more significant one than the clavicular fracture. Malalignments happen a lot, or dislocations, and so here's an example where it should be pretty obvious to y'all that the glenohumeral alignment is abnormal. The humeral head is displaced inferior relative to the glenoid, and usually in this situation it's anteriorly displaced, so it's antero-inferior dislocation, and you can't really tell whether it really is anterior or posterior on this particular view, but if you have a different view, in this case somewhat of a Y view, you can tell that it's anterior. And again, the key handle on this is that if you can figure out where the Y is, so here's scapular spine, coracoid, scapular body, then the glenoid is here. We know that the coracoid is always anterior, so that if this is humeral head here, it's anterior to the glenoid, so that would be an anterior-inferior dislocation. And keep in mind that a dislocation is where there's complete lack of continuity, or lack of contact, I should say, between the joint. So the glenoid and the humeral head are completely lacking contact, whereas a subluxation is somewhere between normal and all the way up to a dislocation. Here's a different patient, actually. So can you tell in this one what direction the dislocation is? So again, the glenoid is here. Here's scapular spine. Here's coracoid. And obviously the chest is all here. So this is another anterior-inferior dislocation of the humeral head. This also shows what happens with the humerus when this happens, is that with the humerus contacting the antero-inferior glenoid like this, you can have an impaction fracture on the humeral head that's called, as I'm sure you're saying to yourself right now, this lesion here, which is a Hill-Sachs impaction fracture. And so it's kind of a hatchet-shaped deformity of the humeral head that's due to the humerus impacting on the antero-inferior glenoid. And often they don't show up well until the patient's been relocated. They show up maybe best on an internal rotation view like this one. Okay, here's another Y view in this patient, just showing that it's been relocated again. So humeral head superimposing over the glenoid. So here's the glenoid here, and there's this bony fragment here, which is separated by this lucency. So this patient must have dislocated, and they have this displaced bony fragment antero-inferiorly, and that's a fairly sizable fragment there. Here you can see it again. Here there's like a double density where the main glenoid's here, and then you have the Bankart component here. Sometimes they're hard to see on the Y-type view And it may not always be possible to get an axillary view in these situations, but here you can see the glenoid through here, and there's a little double density right in here. So that's the bony Bankart, and the size of that is important because that'll help determine whether or not, if a surgeon's going to operate, if the piece is big enough to put back with screws or not. Perhaps even more complicated, an older lady who has fracture dislocation. This is probably the humeral head down here. There's other bony fragments. It looks like there is a component across the surgical neck here. And they were able to get an axillary view on her, which I'm not sure that it really helps a huge amount. But if you just try to get oriented on these axillary views, basically you want to go and try to find the glenoid. Here's the coracoid. Here's the glenoid in here. So the humeral head should be sitting in there. And it's very difficult to see it. Maybe there's something there, but it's really not easy to tell. What's definitely not normal is the humeral shaft should not be coming and superimposing over the glenoid like this, and, because it's so markedly displaced. This patient, it's a little bit off-center, but I hope you can tell that the alignment of the glenohumeral joint is not quite right here. You can see that there's a widened space between the anterior margin of the glenoid rim here and the humeral head, and that should make you think of a different type of a dislocation, in this case not anterior but posterior. And these aren't the most beautiful views here, but you can see on this Y view, remember I keep saying the coracoid should be anterior, glenoid is here, and you can see the whole humeral head is posteriorly positioned relative to the glenoid, so that's a posterior dislocation of the humeral head, which is kind of engaged on the glenoid. Relocated, you can see a better alignment, humeral head now overlapping somewhat with the glenoid. There may be some flattening of the humeral head from an impaction deformity there. A little bit about the AC joint here. So we should always see that the undersurface of the distal clavicle should line up with the undersurface of the acromion. And so this is fairly normal in this situation. There's a normal width of the AC joint. The normal coracoclavicular distance is on the order of like 12 millimeters here. Now, what happens in this patient is there's a little bit of malalignment when they get the other glenohumeral view. So there is some offset there, and that can indicate a low-grade sprain of the AC joint. This was had the injury, and then they came back a few weeks later and had these follow-up radiographs. And here what you can see is that now there is the malalignment seen because the clavicle doesn't line up with the undersurface of the coracoid, the acromion here. And there's this fluffy new bone formation along the distal clavicle. So that's some periosteal reaction related to the stripping of the capsule that occurred with the AC separation in this patient. And it can be a little bit aggressive looking. I've seen cases that almost look like an osteosarcoma developing there after an AC separation. So it's good to be aware that this can occur. I'm not going to show the MRI in this case, but I thought I had another example here of a AC separation. This is a higher grade injury, and in this case, it's pretty obvious that there's a marked malalignment between the clavicle and the acromion. And the thing to remember is that when you go from just injury to the AC joint capsule itself to one where it's that capsule plus these coracoclavicular ligaments, if these are injured, then that becomes a grade 3 injury. And so in this case, this is widened, definitely more than 12 millimeters, and that means that there's disruption of the coracoclavicular ligaments, making it at least a grade 3 injury, and sometimes that's what heads patients towards this being surgical, or at least makes it longer expected healing of the injury. Okay, so let's go back to the other slides for a second here and just look at a couple things on elbow. Just a reminder about the osseous anatomy of the distal humerus and the trochlea that's formed with the articulation with the ulna. The capitellum here, it can be spelled in different ways. Here it's spelled capitulum from the old days. Radial head, radial neck, greater tuberosity of the radius where the biceps tendon attaches, and then the posterior view here where you have the olecranon fossa, where the olecranon goes in, the epicondyles, and so on. Hopefully that's all pretty familiar anatomy to you. The other thing that's worth pointing out is the coronoid process of the ulna. It's kind of similar to the olecranon process, but the coronoid process is anterior. And then the notch that's formed, the whole notch in the ulna where the trochlea is called the trochlear notch here. Okay. The elbow views are fairly straightforward. These are from Greenspan's book, where they show the little cartoon guy and just like a straight AP view of the elbow showing humerus, radius, and ulna. A lateral view, and they show the idealized positioning of a patient for a lateral view where the elbow's like bent like 90 degrees and the thumb is up. And so you get a nice true lateral view of the elbow. And we'll look at a couple of cases involving the elbow now. The elbow is a good joint in the sense that the presence or absence of an effusion is really helpful finding. And this is a fairly young patient, but I think you can see that there's fullness in the anterior aspect of the joint here, this lucency. And then there's also some lucency back here, consistent with a posterior fat pad sign. So this patient has both elbows imaged. This is the right side and this is the left side. Left side's even more impressive. So if you look at this one, this is a classic example of a large elbow effusion where you see lucency anteriorly, this would be the sail sign, and then posteriorly the fat pad sign. And a lot of times the injuries related to these are not that obvious. If you do have this and you don't see any abnormality, the key thing to keep in mind that the most common occult fracture in this situation is what? Radial head, good, or radial head or radial neck. And in this patient, the radial neck just shows a little bit of buckling, like right here. So it's subtle, but a little bit of buckling. Usually, if you have an occult fracture like this or subtle fracture, it's not likely that you're going to be missing a surgical fracture, but you have to just assume, like in an example like this, effusion without any definite fracture on the right side, that there probably is a fracture that just can't be easily detected, and then we recommend follow-up radiographs in 7 to 10 days to see that fracture show up. Sometimes the fractures show up a little bit later over time, and so here's one where there's some subtle sclerosis across the radial neck that wasn't really evident in the very first view, but as it's starting to heal, you can start to see some remodeling start to happen. Let's zoom this back down. This patient, you can see, still has a little bit of an effusion back in here. Another example, more of a pediatric type patient. You want to look at the alignment of the elbow, and the radial head should always line up with the capitellum in all views. So here's radial head lining up with capitellum. This patient's growth plates are not fused yet. Here you can see the kid's got an effusion, right? Posterior fat pad, anterior fat pad. And what's abnormal about this is this lucency right across here, right? So this is a supracondylar fracture of the distal humerus in a younger patient. And sometimes they can angulate further back and really straighten that distal humerus. These are just normal growth plates here. So another fairly common fracture that can be subtle. This one's not so subtle, and I need to get better examples of elbow dislocations. But here you can see there's disengagement of the ulna from the humerus as well as from the radius. And surprisingly, patients will have elbow dislocations, and they may get it reduced in the field, and so they'll come in with like sequelae of dislocation. But it's not all that common for us to actually still be imaging people with the joint completely dislocated like this. And so, like I said, I don't have a lot of great examples of this on this current setup, but the thing to keep in mind is that the bones may not be that abnormal in the sense of the ulna and the radius here are still pretty much intact without major fractures. What you may see fracture of is the coronoid process, as you can see through here. Looks pretty normal, but it can shear off because most of these dislocations are posterior directed dislocation of the ulna relative to the humerus. Here's relocation in that same patient. You can see the bony anatomy is actually intact. Okay, different example here. There's a couple problems with this patient. Again, a young patient. Obviously, there's a fracture involving the mid-ulna here. And then remember, even in kids, you should be able to tell that there's normal alignment of the radiocapitellar joint. Here's the radius, and it's shooting up towards the humerus. Here's the capitellum in here, and it's dislocated, right? So this is like an eponymous abnormality that I'm sure you're all saying to yourselves right now, the Italians. And just remember the whatever the mental hook is you're supposed to use, the mugger, Montesia ulna is the fracture, Galeazzi radius. So this would be a Montesia type injury because the ulna is the thing that's fractured. Montesia ulna Galeazzi radius. Okay. Let me let me switch over to the wrist slides here, and we'll finish up with that. So I've given full lectures before on wrist and hand, and I can't really get through all of it. I wanted to have kind of a synopsis package here because this is a complex topic with not only acute traumatic things, but chronic arthropathies and malalignment things that it's worth knowing something about. So I have a few more slides on the wrist than I did on the other joints. The bones don't usually come across nicely labeled like this, but this is a nice intro slide. This is a really good article from Radiographics a few years ago where they talked about different fracture and malalignment patterns in the wrist and hand, and they're using CT data with volume rendering to show the bony anatomy pretty nicely. So here's scaphoid, lunate, pisiform here, and triquetrum back there. TM, remember the trapezium goes with the thumb, and then the trapezoid with the second metacarpal, and the capitate and the hamate has the hook, right? So that's the 3D anatomy, and then here's the same bones, right? It's the mental hook of like some lovers try positions that they can't handle is what people have often used. But after a while, you just get used to knowing what the bones are. Scaphoid, lunate, triquetrum with the pisiform superimposed, the trapezium going with the thumb, the trapezoid in there, and the capitate and the hamate here with the hook. And the couple things about alignment are really important in the wrist. And the hand surgeons talk about these things when they look at patients with distal radius fractures. So one thing that's not often emphasized is what's called inclination. And if I go back a slide, just remember that the distal radius here, the radial styloid, is more distal than on the ulnar aspect. So there's this angle of inclination of the normal radius here. So if you look at a diagram, the transverse would be C to E, and there's a certain length of this inclination, 10 to 13 millimeters. But another way to remember is just that, well, the distal radius is angled about 21 to 25 degrees compared with just being straight across. And the importance of that is if you have a fracture of the radius, the surgeons are trying to restore normal anatomy. And so they're trying to restore inclination, and they're also trying to restore tilt, which we'll look at in a second. So it's relevant to look at the fracture pattern and ask yourself, is the inclination normal and is the tilt normal? So inclination is kind of in this AP plane, whereas tilt is in the lateral plane. So here's a lateral radiograph of the wrist where you have radial styloid through here. Here's the distal ulna. And tilt is the fact that the palmar, there's a palmar tilt of the distal radial articular surface such that it's about 11 degrees relative to horizontal. So here's the diagrammatic view of that. So here's palmar and here's dorsal. So distal radius, this angle is normally about 11 degrees. So if somebody loses that tilt from like a Colles fracture, That's important because it changes their carpal mechanics. So the surgeons are definitely very interested in that and whether there's maintenance of tilt and inclination. Another angle that's important in the wrist of this is the scapholunate angle, and this it's easier to kind of show in person at some level because you can draw around the bones, but basically this is a critical angle to look at on all wrist radiographs because it delineates the angle between the lunate, this little moon-shaped bone, and the scaphoid here. So this is going to be palmar and this will be dorsal. And the normal angle between those two bones is 30 to 60 degrees. And the importance of that is that if that angle is abnormal, it can indicate disruption of the intercarpal ligaments. And it's most commonly affected by tearing of the scapholunate interosseous ligament. And I'll show a little bit about that in just a second. So compared to a normal, let me just go back another slide here. Here's a normal lateral view of the wrist, and if we outline the lunate here, see it's this little moon, right? That's why it's called the lunate, and it should be kind of neutrally tilted relative to the radius. It should be sitting like a teacup here without being tipped either dorsally or volarly. The scaphoid is through here, and it's kind of peanut shaped. Okay, so if I outline the scaphoid, it's this whole kind of figure of 8 or kind of peanut shaped bone. It's a little confusing because the pisiform is superimposing here. But if you have a line between along the scaphoid here and through bisecting the lunate, that should be between 30 and 60 degrees. And in a normal, you can kind of look at that and eyeball it and say, yeah, that looks about right. Okay, so let's go to these. There's the diagram again. If you go to the ones that are abnormal from the literature here, here's the dorsally tilted lunate. So here's the lunate, and you can see it's tipping backwards. So the bisecting line is this one here. And then the scaphoid going along the palmar aspect of here is like 90 degrees relative to the lunate. So that indicates that there's some decoupling between the scaphoid and the lunate, typically because of a scapholunate ligament deficiency. The opposite situation is where the lunate tips in a volar direction, like this. So here's volar or palmar, and the scaphoid doesn't tip as much. So the scaphoid is still lined up along here, and that scapholunate angle is decreased, causing what's called a VISI malalignment pattern. So the D and the V, so the D is for dorsal, and it's tilting of the lunate. So here's dorsal tilting of the lunate, and it's called a dorsal intercalary segment instability in this situation, or volar intercalary segment instability in this situation. Now, these are pretty advanced concepts that I wouldn't expect like the first years to necessarily know, but as you get to be more senior and you're reading films on your own, it's really important to know these because you'll miss these malalignment patterns, and they're fraught with problems for the patient if you miss these malalignment patterns. Now, if you get lucky and you have a ligament tear, you can actually see widening of these spaces. So here's scaphoid lunate. There's widening of the scapholunate interval here. Normally, these intercarpal spaces are uniform throughout. So if you have this space, then the scapholunate should be about the same width, and that indicates that it's too wide, especially in this is like not even a stressed view here. There's different people that have been associated with this sign. Like this is an old guy named Terry Thomas, who was the first guy for the scapholunate widening kind of sign, and then more modern people like Lauren Hutton, the split in her teeth, and Michael Spinks, he's got the major ligament deficiency there, and Letterman and Michael Strahan. So these are like more modern people, but it was traditionally called the Terry Thomas sign. A couple other things about wrist, and it gets into more detail than we have time for, but Lou Gilula is a bone radiologist in St. Louis, and he made a career really out of looking at carpal alignment patterns and came up with this concept of the carpal arcs, the arcs of Gilula. And basically what he came up with is the idea that if you look at the carpal rows, the proximal row and the distal row here, that it's delineated by these lines that should be nice smooth arcs. So the first arc is along the proximal aspect of the proximal row here, scaphoid, lunate, triquetrum, and the pisiform superimposed, showing that those bones all stay nice and normally aligned in a normal patient. The second arc is along the distal aspect of the proximal row, and it seems a little confusing, but it's basically to show that you could have a rotational problem of one of these proximal row bones that could disrupt this second arc. The third arc is along the proximal aspect of the distal row. So these kind of seem similar. There's a subtle difference between these second and third arcs, but just keep in mind that normal wrist, you should have nice smooth arcs proximally and between the proximal and distal row here. So in real life, here's a nice example, scaphoid lunate cruising along to the triquetrum here. That's the first arc. The second arc would be along here, and then the third arc would just be along the proximal aspect of this distal row. Nice normal alignment. And so here's one where that alignment is disrupted. And so the first arc, be coming along scaphoid, lunate, and then there's not really a nice smooth continuity between lunate and triquetrum here. The principal abnormality in this patient, though, is that it's in the second, and probably the second arc, scaphoid, lunate, and then this juts out abnormally, and then you have this part. So that's disruption of that second arc. And basically what this is telling us is just that there's a malalignment of the lunate in this patient. And this is again from that radiographics article where they had the nice 3D CTs as well. And so here you can actually see this articular surface of the lunate is dislocated relative to the capitate, which it should be sitting in. So there's different terms for this, like this is they called lesser arc perilunate dislocation. And we do see these types of things like lunate or perilunate dislocations where here's the distal radius, here's the scaphoid in here, and remember the lunate here should be articulating with the capitate, so there's the capitate. So the lunate is displaced in a palmar direction. It's not completely out, but it's partially out, so that's what's called a perilunate dislocation. The more final stage of that is called a lunate dislocation, where the lunate is completely dislocated from the carpal bones, and different subtleties about whether the distal row is dorsal or palmar or not. But basically, you should just be able to identify whether there's like a carpal malalignment pattern. Here's another one that you should be able to identify pretty easily, or at least identify that it's abnormal. All those arcs are disrupted, right? Proximal arc, second arc, third arc may be okay, but there's a fracture across the scaphoid here. The lunate is looking like it's malaligned relative to this distal row. There's a little fracture fragment in here, probably something old here. And so this one is that similar kind of perilunate dislocation, but there's also a fracture of the scaphoid. So this one is termed a transscaphoid perilunate dislocation. And again, all the exact terminology is not that important as long as you recognize what the different injuries are. So let's finish up with a few cases of the wrist here, and then we'll be good to go to work. So let's see here. So here's a pretty basic example, and I'll try to zoom in on these things, and window level. So fairly good alignment of the proximal carpal row here, but there's a little bit of widening of the scapholunate interval. And there's also something abnormal with the radius here, right? See this sclerotic line, a little lucency. So there is a distal radius fracture. It's probably intra-articular here. The question is whether that scapholunate interval is abnormal or not. And so if we look at the lateral view, you can see if we can figure out that scapholunate angle here. And if I zoom in on that, so let's just take care of the distal radius. So normally, like we said, that should be an 11-degree palmar tilt to the distal radius, and you can see this looks like it's neutral. So there's some dorsal impaction of the fracture, and it'd be called neutral tilt of the distal radial articular surface. If you looked at this PA view again, say, oh, the inclination is actually maintained, isn't it? So this one I would dictate and say, inclination is maintained, but there's slight dorsal tilt or neutral tilt of the distal radial articular surface. And those are things that the hand surgeon would decide about whether or not to try to improve on that alignment. Coming back to that scapholunate, okay, so here's dorsal, here's palmar, and if you look at the lunate here, it's in here, it's a little bit tilted dorsally, right? Here's the capitate, which sits in the lunate. We won't get into it, but you can talk about the angle between the capitate and the lunate as well. So lunate's tipping dorsally. Here's the scaphoid here. I'll just kind of cruise around the borders of it, like here. Okay. And if you just draw like a long axis either through the middle of it or along the palmar cortex of that scaphoid, I think it's pretty easy to see that that's going to be more than 90 degrees. Let's see if I can do that quick. So here would be like bisecting the lunate, and then here would be along the palmar aspect of the scaphoid here. And it's this angle we're looking at right there, which you can easily tell is more than 90 degrees. So that's a scapholunate malalignment, and that's the DISI, dorsal intercalary segment instability type of malalignment pattern. Now, it's not necessarily acute, but it's an important thing to know that this patient also has that in addition to the distal radius fracture. Different example here, just looking fairly normal, right? Proximal row, second arc, pretty good. Maybe the lunate's a little bit malaligned there. And when you look at the lateral view, this windowed, the scapholunate angle in this patient is actually pretty normal, right? Here's the lunate here, here's the scaphoid, distal radius, okay. The thing that's abnormal is this little ossicle right here. And that's a pretty typical fracture fragment that we see that's usually from what bone? Triquetrum, yeah, right. So you can't always, in fact, you can rarely see where it actually arises from because it's such a small fracture, but if we see that fracture that's kind of halfway between the proximal and distal row, dorsally in an acute setting, often with some soft tissue swelling, we'd say this is typically related to a triquetral fracture. Okay, different patient here. Let me see if I can get this not for medical usage on there because it's so annoying. Let's see. Here's a different patient. So we're going to zoom in a little bit here. Clearly they have a fracture of the ulnar styloid process. There's maybe a little bit of widening in the scapholunate interval here. Hard to tell really. Anything definite in the radius? Not necessarily. Pretty good. Here's the lateral view. And if you look at the alignment, pretty good normal palmar tilt. Scapholunate angle is a little bit difficult to see here. And one of the things you have to be careful of is that you have to have just a good lateral to be able to assess that scapholunate angle. I think this case is in here because it showed that the fracture line showed up better later on as opposed to acutely. So I'm going to kind of skip to this next case here. Here's one where you see scaphoid and you see lucency across the scaphoid waist, right? So that's going to be a scaphoid fracture. And if they were all this easy, life would be good, right? Because this is like a pretty clear-cut lucency across the mid-scaphoid waist without any malalignment. And, whoa, can't really see it that well on the lateral view. You see it nicely on the scaphoid view here. And one thing to keep in mind about these is that, you know, if you get the scaphoid view and you see the fracture, that's helpful and it can be confirmatory or diagnostic. But if you have the scaphoid view and you don't see the fracture, don't be reassured by that, because it may be that the fracture orientation is just such that you can't see it in this view, and you have to be very suspicious looking at the other views as well if there's a concern about a scaphoid fracture. And this is one of the situations where we always will say, if high suspicion, consider follow-up, or recommend follow-up films in 7 to 10 days, because we know these can be radiographically occult, and they're a big source of medical legal problems and chronic problems for the patient if this doesn't heal and goes on to like avascular necrosis, for example. All right? Couple more examples here. So another triquetral fracture, little dorsal chip there. I think actually this is the one where reminding us not to get too satisfied about our search pattern. So we see the triquetral fracture, really nothing else definite, but when the patient comes back, this is the guy. No, sorry, just he comes back a couple weeks later, and basically we're just still seeing evidence of that prior triquetral fracture. Sorry, I thought I had one that was a distal radius fracture that was showing up better on the follow-up films, maybe still in here, but I'm a little bit out of sync. So take a look at this one, different patient, and check out the carpal alignment. This is kind of like that example on the in the slides. Proximal arc, pretty good. The second arc, not quite right? And it could be because the lunate's kind of projecting out like this. It's difficult to tell about the scapholunate interval because of the projection, but it's a little suspicious that it's malaligned here. So there's the oblique view, and then here's the true lateral view. And hopefully after seeing a few of these, you can say, aha, yeah, that's definitely not normal alignment pattern. Got to figure out which is palmar and which is dorsal, which should be pretty good. But this lunate is dorsally tilted. Scaphoid's all in here. So you can see the scaphoid line would be like this, lunate like that. So that's another example of a DISI, dorsal intercalary segment instability kind of a pattern. And I would say over the years, I've seen quite a number, maybe 10 patients like this. Actually, the PA and the oblique views are normal, but the lateral view is the only clue that there's an abnormal alignment pattern, and that's a really important thing to pick up because you're identifying probable ligament deficiency that otherwise you cannot detect on the other views, and that's often a surgical repaired situation. So you really want to be careful about looking at that on the lateral view. This one, okay, again, so hopefully by now you're seeing a pattern here where you can definitely identify these malalignments. So here there's abnormal alignment of this proximal arc, right? Here's the scaphoid, it's kind of tipped down, the lunate's kind of tilted, and then the triquetrum is not lining up nicely with the lunate either, okay? The distal arc is in pretty good shape. If you look at the other views here, okay, and again, remember to figure out which is volar and dorsal. So in this case, the lunate is tipped in a volar direction, and the scaphoid is here. So and that's going to be decreased scapholunate angle. Right, so here you would you'd bisect the lunate like this, and you'd go along the scaphoid, and you just go like mid scaphoid like so. Looking at this angle here, and if it's below 30, then that's abnormally low, and that's a VISI, volar intercalary segment instability type pattern. And compared with the scapholunate one, this goes along with lunotriquetral ligament deficiency. And so scapholunate ligaments in here, lunotriquetrals in here, and you can see the lunate and the triquetrum, and you see they're malaligned right there because the ligament between them has been disrupted. And one of the best clues for that is on the lateral view here. Here's one that's kind of similar to what I just showed, where there's 3 views. You can see there's disruption of the carpal arcs, and on this lateral view, you can see that the lunate is starting to be displaced in a volar direction. So lunate's tipped out here, it's disengaged from the capitate, there's some little fractures. It's not quite all the way out yet, but this would be compatible with one of those perilunate dislocation type injuries. Here's one that like the janitor should pick up as they walk by and say, man, look at that carpal dissociation pattern, right? So if you miss this as a resident, you're probably in the wrong specialty. Now you might just say, boy, that's totally jacked up, which is probably a reasonable first approximation because it can get really difficult to figure out what's going on with these. If you look at this lateral view, what you want to try to identify are, the general alignment situation of the bones. And see, the distal row with the metacarpals is here. Here's the lunate here, and so we can probably tell, well, that looks like that's palmarly displaced. There's some fragmentation of the dorsal radius. And the other thing is on this PA view, really not seeing the proximal pole of the scaphoid very well. So that's got to be somewhere, right? And this looks like the lunate over here. And basically, you know, it may be really difficult to know what's what or where things are, and these are almost always going to get CT scans. But you can tell this is like a carpal fracture dislocation pattern and clearly needs more workup and attention by hand surgery. Little things like this can be really important too. So this is a thumb injury with a small fracture at the base of the middle phalanx of the thumb, and this one may not be entirely acute, could be subacute, could be a little bit old, but what's this? What's the eponym for this fracture? What's it called? Gamekeeper's thumb, right? Yeah, so this is indicative of injury to the ulnar aspect of the thumb MCP joint and the ulnar collateral ligament with a bony avulsion kind of fragment in there. And I think I just have one or two more cases here. This just gets to remind us that, you know, one view is not enough, and so you have the distal DIP joints here, and then on a lateral view you have this dorsal fracture fragment. I think this could be termed a mallet type finger where there's a bony avulsion of the dorsal proximal cortex. Don't worry about this little shark fin thing. I don't know what that is, probably old injury. But these are important because they may distract over time. They usually will heal up okay, but you can only see it really if you look carefully at the oblique view and the lateral view. This one's obviously not that subtle. What happened to my 49ers the other day, and this is actually the hand of a cornerback who plays for the Seahawks that dissed one of our 49ers wide receivers, and so we got a hold of him and we put his hand into a wood chipper just to kind of try to teach him a lesson. All right, so hopefully he won't mouth off anymore. But you can try to figure out what these little nibbly bits are that are left of his hand here. So he'll learn from that. All right, so that's the end of the slides and stuff. And so kind of went over some quick shoulder, elbow, wrist, and hand things, hopefully with a little bit of review and some new tidbits. And I will save this recording and post it online as soon as possible. So thank you for your attention, and I'll look at the list here to see if there's like complaints and questions, because we could take a few of those probably offline.